First, I need to describe the population that we are testing on this study. Patients with triple-class relapsed refractory multiple myeloma presented a bad prognosis because of conventional therapies resulted in an overall response around 20%, and the progression-free survival and overall survival of this population were inferior to 6 months and 1 year respectively, according to the data of locomotion and mammoth studies. In this scenario, novel targets have appeared like GPRC5D or BCMA to attack the clonal plasma cell with bispecifics, monoclonal antibodies, and CAR T cells. Different studies have demonstrated that CAR T and bispecifics are effective in this triple-class population. However, there are not studies comparing both therapies, and there is a lack of evidence on how to treat patients who relapse after both novel immunotherapies. And this is the rationale of our study. We designed a study in order to compare patients with triple-class relapsed refractory myeloma treated with bispecifics and CAR T and explore the rescue therapies used in this population. 73 patients were included in our study, 36 treated with CAR T and 37 with bispecifics monoclonal antibodies. Regarding the baseline characteristics of the patient, both groups were comparable. 60% of patients were penta-exposed and 20% penta-refractory. No difference regarding baseline characteristics, except that patients of the bispecific group were older, had more extramedullary disease at the moment of the relapse, and were more pretreated, with near to 70% of patients of the bispecific group with more than 3 prior lines of therapy. Following with efficacy, patients of the CAR T group achieved a significantly higher partial response or better, near to 100%, compared to 60% of the patients of the bispecific group. In addition, the complete response or better in the CAR T group was near to 70%, compared to the 40% of the bispecific group. Despite of this difference in response, no difference were observed in progression-free survival between both groups. 16.6 months for the CAR T group and 10.8 months for the bispecific group. One of the most important findings in our study is that patients of the CAR T group presented significantly longer overall survival, 4 years, compared to the 2 years of the patients of the bispecific group. And in order to understand the difference between both curves, we decided to explore the rescue therapies of these patients. Most patients of the CAR T group were rescued with bispecific monoclonal antibodies, especially against GPRC5D. In contrast, the salvage treatment of the bispecific group was more heterogeneous, highlighting the use of the bispecifics, immunomodulatory-based schemes, and proteasome inhibitor-based schemes. More than 80% of patients of the CAR T group rescued with bispecifics monoclonal antibodies achieved partial response or better, and the 30% complete response or better. That was significant, numerically and significantly higher than patients of the CAR T group rescued with other schemes different to bispecifics, and patients of the bispecific group regardless of the therapy used at the moment of the relapse. The response of this remaining group of patients were ranging from 30% to 50% of partial response or better. And this difference in response were reflected in survival, and patients, the sequence CAR T followed by bispecifics monoclonal antibodies resulted in the best progression-free survival, almost 2 months, compared to almost 2 years, compared to the remaining sequencing approaches. And based on these results, we can say that bispecifics could be an optimal treatment after CAR T. However, we haven't got data out patients with the bispecific group treated with CAR T, and we can compare both populations.